Okay.
So thank you for the invitation. It is my pleasure to be at BMPA again after such a long time. And what I'm going to do with you is a brief overview of the concept of psychiatric side effect anti-seizure drugs, because I'm sure that all of you are familiar with this topic in particular. This is my disclosure. So we have now more than 20 drugs, almost 30 different anti-seizure drugs. There has been a constant flow of new drugs in the last century, starting from almost 100 years ago. This was driven primarily by having very good animal models of epilepsy since the very beginning. Epilepsy was one of those conditions that could be replicated in a rat. And some of these rats were able to be associated with the effect of a specific compound on a specific seizure type. The maximal electric shock model or the subcutaneous pentylentetrazole injection were associated with an effect on tonic-clonic seizures, while the amygdala-kindled rat was associated with a good effect on focal seizures, especially temporal lobe epilepsy. But apart from these very primitive animal models, we have a number of different animal models, the photosensitive baboons, the genetically modified rats. So over time, industries and researchers had the possibility to screen a number of compounds that were not even developed initially for the treatment of epilepsy to understand whether anti-seizure effect could have been a target. Then in the 80s, we found out that these animals just mirror the effect of this compound at a specific synaptic level, and we know that the anti-seizure effect of the known drugs is mostly focused on increasing GABAergic neurotransmission, reducing glutamate neurotransmission, or changing the excitability of neurons, modulating channels. There is then a number of drugs that simply represent the improvement from a chemical point of view of known compounds. We have the third generation of carbamazepine, that is eslicarbazepine through oxcarbazepine. Eslicarbazepine can be taken once a day, is not an inducer, is not associated with hyponatremia, a big advantage. Leviracetam and brivaracetam represent the evolution of piracetam. But since the very beginning, the history of anti-seizure drugs has been always associated with psychiatric disorders, mostly because 100 years ago, psychopharmacology didn't exist. We had a drug that could act on the brain. Why not trying in other brain conditions? So, as you know, Merritt Putnam described the effect of phenytoin in 1938, and Parker Davis immediately marketed, not even regulatory trials. But after a few years, we have the first publication about the use of phenytoin in schizophrenia, and a number of publications on this topic, mostly about sedation, reducing agitation. Carbamazepine was developed by Ciba-Geigy in the 50s. They were looking for a new antidepressant because imipramine has been transformative for the treatment of depression. So they were looking for another tricyclic because carbamazepine has a tricyclic structure very similar to imipramine, but didn't work as an antidepressant, was used for trigeminal neuralgia, and only after a decade they decided to use in an animal model of epilepsy, and it worked. So starting from there, they started using in epilepsy. And because anti-seizure drugs can be effective in the treatment of psychiatric disorders, after a while, we have the first trials in bipolar disorder. Subsequently, all drugs have been tested in psychiatric disorders for the treatment of all of them. This was mostly driven by the famous hypothesis of the kindling that was developed by Bob Post in the 70s and remained very influential to try to support the use of anti-seizure drugs in psychiatric disorders. So up to now, up until that time, Anti-seizure drugs were seen as positive, able to improve psychiatric symptoms. The first report that anti-seizure drugs could make behavior worse and could lead to psychiatric presentation is probably the forced normalization phenomenon, described by Landolt, that was the head of the epilepsy center in Zurich. I'm sure all of you, I mean, this is a neuropsychiatric conference, know what forced normalization is. But for a number of years, this concept remained mostly in the German literature, because most of the papers of Landolt were written in German and became widely known through Michael Trimble, that published this book and translated a number of papers and started talking about forced normalization to the wider English-speaking audience. But still, this could happen, so a negative effect of anti-seizure drug was something anecdotal, rare, something deserving a publication because it's so rare that can be seen only in the clinic of extremely renowned specialists and deserves a publication. This is a case series of patients developing psychosis with vigabatrin, something exceptional. So it took some time to understand that this was not an exceptional thing. Obviously, vigabatrin brought to the attention of clinicians that anti-seizure drugs could have a negative impact, but still was not considered something that a general neurologist in Halifax could have seen in his clinic, okay? Not a routine thing. The big change was with the first meta-analysis of the regulatory trials of vigabatrin, because Devinsky showed that people treated with vigabatrin during the regulatory trial had a 7 times, almost 8 times increased risk of developing psychosis as compared to placebo. And also for depression, almost 4 times. So this obviously brought that this is something that we need to explore more routinely. But still at that time was seen as a vigabatrin only thing. This is a very specific drug with a different mechanism of action. It's not going to happen with other drugs because side effects of anti-seizure drugs are mostly drowsiness, memory issues, but you cannot become depressed or agitated or aggressive because you take a medication. But Professor Trimble's view was different. He always thought that this was a routine thing that we had to look at. And at that time, I had the privilege of working with him as a young doctor, and we started looking at it in a systematic way with 2 drugs that were widely used, topiramate and levetiracetam. And asking routinely to people, we saw that this is not something so rare, but between 1 in 10 and 1 in 5 people in a routine clinic can report that the anti-seizure drug made their behavior worse. Why was that? Obviously, it was partially related to how we used the medication, titrating the drug quickly or associating with other drugs. This could have been related to the fact that they had severe forms of epilepsy, or the major temporal structure were affected, so an aberrant temporal limbic networks, for example, as predisposing factor, but also because they had a strong biological predisposition, so a previous psychiatric history and a family psychiatric history, so having a genetic background that interacting with the epilepsy was going to predispose them to this kind of reaction. Another important piece of information at that time was that many drugs used to go into clinical trials for marketing outside epilepsy, so it was not just a matter of animal models. Levetiracetam, for example, in the 90s, was initially marketed as an anti-dementia drug. And the first clinical trials were in MCI and Alzheimer. Now there is a research, because obviously companies need to find a way to resell their drugs when the patent is gone. But in any case, the very first trials of levetiracetam were in cognitive problems, and they have also tried in anxiety disorders. So in this paper, they looked at the prevalence of psychiatric side effects, in particular depression, during the clinical trial for epilepsy as compared to the clinical trial for dementia and for anxiety. And this was something more frequent among people with epilepsy, not with other conditions. So it is not just a matter of a specific drug, it's the interaction of that drug with a substrate that is that represents a risk factor for it. So the usual question, what drug is easy to use? What drug is more or less associated with these problems? This is not an easy question to answer. One way could be to look at the prevalence of these side effects in the regulatory trials. According to the regulatory trials, the very old drugs are very safe, although at that time there were not really regulatory trials. So these data cannot be really compared. In most of these regulatory trials, complex patients with psychiatric disorders are excluded. They are observed just for 12 weeks. So this is not definitely a source of information to predict what drug is more or less risky in that sense. So look at pragmatic studies. We are in the UK, we have the SANAD. SANAD 1, they looked at psychiatric side effects in the focal epilepsy study. You can see topiramate is the one with high risk. Then we have levetiracetam, definitely better for other drugs. Guys, you are very optimistic if you expect me to see this in the screen, but in any case, that's fine. I'm saying for the subsequent speakers of my age. In any case, SANAD 2, we have more recent drugs. We have, again, levetiracetam, zonisamide, and lamotrigine. Lamotrigine is always better than others in terms of prevalence of psychiatric side effect. The same thing for the SANAD in generalized epilepsies, where they compared levetiracetam and valproate. Levetiracetam is, in all the studies, more or less associated with 1 in 4 patients developing some sort of psychiatric side effects. Then we have the famous Martin Brody database that is used for everything. It was used also for psychiatric side effects, and Martin pointed out that sodium channels blockers are in general better than all the other anti-seizure drugs because they are associated with a very low propensity to this. Okay, but these are general statements, and patients are different, so we should try to stratify this risk as much as we can. For depression, we have some data about the risk factors that are associated. Depression as a side effect happens mostly with drugs increasing GABAergic transmission, but mostly the AMPA blockers. The AMPA blockers represent the highest risk drugs. When we titrate them very quickly, in someone with a biological propensity, so they had depression already, or there is depression in the family, when the mesolimbic structures are affected, not necessarily from a structural point of view, but even from a functional point of view. Normal-looking hippocampi with febrile seizures in childhood already tell us that those hippocampi are not functioning normally, even if the MRI looks entirely fine. How these variables interact together. So this is a study of many years ago, but gives you an idea of how these variables, the magnitude of the effect of these variables together. For example, for depression related to topiramate, if you titrate rapidly topiramate, you start 50 and you increase by 50 every week, the risk of that patient to develop depression is around 5 times compared to the standard titration of 25 milligrams. But if you do that in someone that has a previous history of febrile seizures, this risk increases by 12 times. If you do that in someone with a previous history of depression, it increases by 23 times. So when we have a patient in front of us, we should try to work out what is the individual risk for that patient, keeping into account all these different variables. And this never means avoid something. This is a way for us to provide information to patients. Our job is not to scare them or to take a decision on their behalf. Our job is to inform patients about the potential side effects of drugs, because these side effects don't happen in 100% of patients, and that drug may make the patient seizure-free. For psychosis, we have a very good data from the group in Melbourne. They looked at a very large database. The first point that they make is that when you see someone with epilepsy and psychotic symptoms, anti-seizure drug should not be at the top of your differential, because only 1 in 7 cases is due to the medication. In the large majority of cases, is either a postictal psychosis or a chronic psychosis or stuff like that. All cases of drug-related go into remission, discontinuing the drug. And the main thing that they have identified is, again, temporal lobe epilepsy, temporal lobe involvement, and a specific association with levetiracetam. We have only one nice systematic review about forced normalization. Peter Wolf made a collection of all the cases published. He pointed out that this phenomenon happens equally in generalized and focal syndromes, that not necessarily is associated with drugs. This is related to something happening in the brain when seizures are controlled. Can happen with VNS, can happen with surgery. This is a very nice case of a patient that developed the same phenomenon when VNS was switched off. This is just to say that there is a modulation of some networks and probably the activation of aberrant networks when seizures are suppressed, not necessarily by the effect of a specific action, drug or VNS. This is an LGS patient. This is the EEG before becoming completely unwell, and this is the EEG when the VNS was off and it was particularly aggressive. So again, not necessarily is related to the specific effect of something. The EEG has substantially improved. Aggressive behavior is a very complex symptom, okay? When someone says, since he's taking this medication, he's more aggressive. But what is aggression? Aggression due to what? It is a symptom that can happen in a variety of different clinical contexts, especially in epilepsy. With some colleagues, we looked at all the clinical studies for anti-seizure drugs and how frequently aggressive behavior was reported. You know that in pharmacovigilance, something very common is something happening more than 10% of the time. A common side effect is between 1 and 10%. So looking at common side effect aggressive behavior in clinical trials, this is the number of drugs associated with that side effect as a common side effect. So even drugs that probably you never thought about, valproate, pregabalin, clobazam, they happen in people with learning disabilities. So obviously there is an association or a weakness of people with learning disability to this specific, but it's a common, really common side effect. So it is always important to understand what there is behind the aggressive behavior if there is a specific clinical diagnosis. Then the suicide alert. The suicide alert, you remember, it was almost 20 years ago, the FDA came with this. It was not something unknown to clinicians. Even before the FDA, we published this report about suicidal ideation with levetiracetam happening, interestingly enough, in seizure-free people. So obviously not related to a failure of treatment. And I don't need to tell you the limitation, but the very good thing of the FDA alert was that finally they took out the stigma of speaking about suicide in epilepsy in general, and also promoted a number of studies in this area. This was one of the studies that came out shortly after the FDA alert. And this is a case control study where they looked at anti-seizure drugs in epilepsy and in a number of psychiatric conditions. The first thing that you can see is that epilepsy is the only one where people not taking anti-seizure drugs have a higher odds ratio compared to people on treatment as compared to depression and bipolar disorder. This is not statistically significant, but in these cases you see that when they are treated with anti-seizure drugs, their odds increase. Epilepsy is the only one where it is the other way around. And in fact, they showed that being on anti-seizure drug is associated with a 50% reduction of chances of becoming suicidal. What does this mean? That probably is not the drug, is having epilepsy that represent a risk factor for development of suicidal ideation, and people with epilepsy represent a high-risk population in themselves. At that time, the ILE asked me to chair a task force dedicated to this, and we published the very first report, first of all, about suicide in epilepsy, and then we had the opportunity to promote a number of actions about suicide, speaking finally about suicide prevention strategies for people with epilepsy, trying to push neurologists to discuss about this topic with their patients, screening routinely for depression, because obviously having active depression represents the main risk factor for this, for our patients. And obviously for all the new drugs coming out to be able to show data using standardized instrument. Finally, the ILE also recognized the suicide as one of the epilepsy-related causes of death in epilepsy. We have now some data about the new drugs. Here we have cannabidiol, brivaracetam, and then obviously perampanel, I think, cenobamate. None of them is associated with an increased risk of suicidal ideation or suicidal attempt. Now, I want to go to the very last topic, that is are we able to predict what can happen in a patient when we start on a new drug? One way is through cross-sensitivity. We have some data about the risk of developing a side effect when someone has developed that side effect with another drug. Cross-sensitivity at the moment is very strong only for levetiracetam and zonisamide, meaning that if you develop depression with levetiracetam, you have a 3 times increased risk of developing the same with zonisamide and vice versa. This group in Calgary, they supported an index to provide some information to patients. If you have at least 4 of these risk factors, the patient has a 49% chances of developing a side effect with levetiracetam in the subsequent 2 years. I mean, this is just taking the history in a good way, okay? Because if someone has 4 of them, obviously there is a strong biological predisposition. For genetic tests, nothing available. There is a single dopamine transporter that was associated with side effects of levetiracetam, was never replicated. This study from a larger consortium identified a number of genes generally associated with an increased risk of psychosis in the general population as a risk factor for levetiracetam. And this is a single study associated with an HLA haplotype. So at the moment, we don't have a prick test able to predict if someone is genetically predisposed to develop a side effect with levetiracetam, but maybe we will manage. So to conclude, anti-seizure drugs, all of you know, have a number of effects on behavior beyond the anti-seizure effect, and these are related to a combination of different risk factors related to the epilepsy in itself and related to the individual biological predisposition. This means that we should always remain vigilant with any drug. And are the new associated with more side effects? I don't think so. I think that the new are probably safer in some ways. There is definitely more awareness. So we identify things definitely quicker than it used to be, and this is why we are always in this alert mode. But more or less, it is always the interaction of the same mechanism of action with the same biological ground. Thank you.
Fantastic. Hello, yeah, fantastic. Thank you again for such a brilliant talk. Vaughan, we've got some questions online.
This is a question from Matthew Hotop from the online audience. Thank you for a very helpful lecture. Do we know the outcome of anticonvulsant precipitated depression or psychosis? Does it spontaneously remit if you stop anticonvulsants?
Yes, if it is a true anti-seizure medication related. This is why when I say to patients that I'm not entirely convinced, I say, look, it is difficult to dissect out the extent you will improve, because obviously if you had depression on the background and you were not in remission from the depression and simply your depression deteriorated with the drug, you will improve to some extent, but not necessarily go away, with the risk of having more seizures. So if it is definitely associated with the drug, the patient had absolutely never had depressive symptoms before starting the medication, yes, disappear completely.
Well, I think Nick Medford had his hand up.
Sorry. Thanks very much. My question is about patients with acquired brain injury who, when they come into the neuropsychiatric unit, usually coming in from a general hospital where they've had the sort of emergency and acute treatment, and they're almost always been started on levetiracetam, and very often they've not had a seizure, or no one thinks they've had a seizure, but they've been put on it because, well, they've had a brain injury, they're now at increased risk of seizures. And then, of course, when they come into the neuropsychiatry unit and you see mood disturbances and challenging behaviour and things like that, there's often this question of whether the drug is contributing. And I think in some cases, as you just said, if you bite the bullet and withdraw it, you see a dramatic psychiatric improvement. I just wonder what you think about that, because that seems to be pretty standard practice, that people just get started.
Okay, yeah. Anti-seizure drugs are seizure suppressants. Yeah. They should be prescribed in someone who has a high risk of recurrence of these seizures. Okay, there is no evidence we can discuss, because it is an esoteric topic, but in any case, there is no evidence that seizures have anti-seizure drugs have a neuroprotective effect. Okay, for a traumatic brain injury, we don't even know all the sequence of biological changes happening in the brain and what they lead to, because obviously there are some biological mechanisms that can lead to epilepsy, others to the cognitive problems, others to the behavior, we don't even know the timing. Okay, giving the drug 1 hour after the TBI, 2 hours after the TBI, 24 hours, does it make any, we don't even know that, even in the famous rats. So there is absolutely no rationale for that, no rationale for neurosurgical operation, nothing. So the drug should be discontinued. If someone has a seizure and the drug was discontinued correctly, you can say, unfortunately, you have developed post-traumatic epilepsy. Okay, so I don't know if you have neurology support in your unit, but say to your colleagues, no, this is wrong. Okay.
Thank you very much. I'll quote you on that. Thanks.
I know.
I'm afraid no more time for questions in the interest of keeping the programme moving on. So